Hello, my name is David Sohn. I am an orthopedic surgeon specializing in sports medicine and shoulder reconstruction. I am a professor of orthopedic surgery at the University of Toledo Medical Center and the chief of the shoulder and sports medicine division. The following are going to be a series of instructional videos. These are primarily aimed at my patients, just explaining what the procedures are, what the conditions they have are, as well as the post-operative requirements. If you want to just watch it, just to kind of learn something on Chalk Talk orthopedics, feel free, and thanks for visiting. And if you have any requests for any additional videos, please let me know. Next, I would like to talk about anterior cruciate ligament, or ACL, injuries. The ACL is one of the 4 major stabilizing ligaments of the knee. When we look at the knee in profile, we see the ACL comes in like this. It helps prevent anterior translation of the tibia relative to the femur. When the tibia translates anteriorly, it puts stress on this structure, the posterior horn of the medial meniscus, because the posterior horn of the medial meniscus acts as a chalk block. If you pull forward too much, there's a shearing force on the posterior horn medial meniscus. This is why at 10 years, people who have untreated ACL injuries have a 100% chance of tears of the posterior horn medial meniscus. For this reason, for people who have complete ACL tears, particularly people who are active in sports or wish to work or play on slippery or uneven surfaces such as hiking or at the beach, we do recommend ACL reconstruction. So the ACL, once torn, typically cannot be repaired. There are some exceptions to that, but typically the ACL cannot be repaired. It would actually have to be reconstructed. And the way we would do this is we would take hamstring tendons and drill tunnels so that we could bring in the ACL graft here into the knee. From a side profile, it would look like this. And it will be secured by a small metal button here, and a staple here, and a bioabsorbable interference screw here. Post-operatively, it's important to know that the ACL does not reach its full strength until 6 months. It actually goes through a period where it remodels. So overall strength versus time. It starts off strong, and then right about here at 3 months is that maximum weakness. So we want to avoid playing sports, even if the knee feels good. We want to avoid playing sports. We want to avoid work on slippery or uneven surfaces, and this includes hiking or walking on beaches, until the 6-month mark, where it will reach its full strength. Other than that, the ACL recovery is not very arduous. You are allowed to walk immediately on the ACL. You do need to use a brace for those full 6 months. The first 2 weeks will be a big, stiff, and uncomfortable brace. But then after those first 2 weeks, we will exchange that for a smaller, lighter, and more comfortable brace. Physical therapy would start at 2 weeks. Next, I would like to talk about post-operative care after surgery. Because the surgical dressing you have on was put on in a sterile environment, I would ask that you keep that on for a full 48 hours. the surgical repair, the incision itself, achieves 90% of its strength within just 48 hours. So at that point, it is okay to remove the dressing, and you do not need to put any new dressings on. It is one and done. However, I would like you to keep it clean, dry, and intact. At that point, it is okay for showers. I would ask that you not take baths at that time. No baths or whirlpools or swimming pools until the 2-week mark. Once we're at 2 weeks, the surgical incision has reached 95% of its strength, and at that point, it would be okay to soak in a bath or a whirlpool situation. I would also just like to say one thing on how much time to be taking off for work. It really depends on your job descriptions. If you have a job which is essentially a sit-down job or a typing job, something where you don't have to either stand or do anything active, then you can return at 2 weeks. If you have a job where you do have to walk around and do some minimal work, such as being a hostess at a restaurant, leading people here or there, but not really having to carry anything heavy, then you can return at 6 weeks. If, however, you have a demanding job, something where you're lifting or you're working on heavy machinery, if you're walking on slippery or uneven surfaces, then you would need a full 3 months off unless there can be work accommodations made for you. We will be seeing you at 3 different time intervals. First, at the 2-week mark. This is mostly for a wound check and to remove sutures, if any. At that point, we typically will order some physical therapy. I would like to see you again at the 6-week mark. This is the point at which I will assess whether you need additional physical therapy or not. Finally, I would like to see you at the 12-week mark. This is typically the final visit, unless there are some lingering strength or motion issues that need further treatment. These are the time points where we can also refill any narcotic pain medications at the 2-week, 6-week, and 12-week marks. One note about postoperative pain medication. The state of Ohio has a law that medications can only be prescribed by one physician and only one pharmacy can be used to fill out those pain medications. This applies only to controlled substances, not to non-controlled substances such as Motrin or Tylenol. When we talk about pain medications, different medications have different mechanisms of action. So I like to use what's called multimodal anesthesia. This means we use medications that have 3 different mechanisms of action, and they can then synergize. When there's pain, I'll just draw, for example, a muscle here, a muscle that's in pain. The way it works is these will release prostaglandins to your nerves. This is a nerve. And then pain stimulus will travel between one nerve to another nerve. And ultimately, that reaches your brain, and your brain then interprets this as pain. This connection here is called a mu receptor. The receptors in your brain are called the C2 receptors. Different medications will affect different pathways. Motrin or other non-steroidal anti-inflammatories will act to knock out the prostaglandins. Opioids, such as Norco or Percocet, will act to knock out the mu receptors. But what's important to know about this is this happens only on a temporary basis. It's through a mechanism called competitive inhibition. When you take opioids consistently for more than 90 days, you then have a potential, actually a 60% chance to become addicted, because the body will then upregulate and create more of these mu receptors. This will require a need for more opioids in order to achieve the same pain relief. For this reason, we do not prescribe opioids for more than 90 days. Finally, Tylenol will knock out the C2 receptors. So this is why we use a pain medication profile that involves all three of them. My recommendation would be to use as your baseline medication ibuprofen, 800 milligrams, 3 times per day as needed postoperatively. If this is not enough, then for breakthrough pain, you can use either Percocet or Norco. But this is your mainstay. This is the main medication you are using. If you don't have pain, don't even take this. If you have pain, take ibuprofen. If you have pain even taking ibuprofen, then you can take the Percocet or the Norco. Both Percocet and Norco contain Tylenol and opioids. So you can see this combination will hit all 3 parts of the pathway. I also wish to be clear about what we will prescribe and when. Because we want to do something called tapering, right? We're going to prescribe opioids just at the very beginning, but then each prescription we give will be less and will have to last longer. So at the 0 to 2 weeks, we will prescribe 27 tablets of Percocet or 40 tablets of Norco, because Norco contains less morphine equivalents. So we will prescribe this at the time of surgery. At the 2-week mark, 2 to 6 weeks, we will refill the exact same thing. 27 of Percocet or 40 of Norco. This will be refilled at the 2-week mark, but now it has to last for 4 weeks. Here, it lasted for 2 weeks. By lasting for 4 weeks, we're having the response. So it's important to know then, these 27 tablets of Percocet will have to last for 4 weeks, for a month. This means that you cannot take more than 1 Percocet per day. Finally, at the 6-week to 12-week mark, we will give another 27 of Percocet or 40 of Norco, but now this has to last for 6 weeks, right? So it's the same amount, but they're having to last longer and longer. This way we can taper you off and not have this upregulation of your mu receptors, right? Finally, at the 12-week mark, if necessary, 20 tablets of Percocet or 30 tablets of Norco can be given. Non-controlled substances like ibuprofen or plain Tylenol can be prescribed at any time. Well, thank you so much for watching. I hope these videos were helpful. If you have any questions or if there are any other videos that you would like to make things more clear or other topics you would want me to explore, please let me or my office know.